that particular proportion group. So this is about obesity prevalence in particularly in India. What about osteoporosis? And this is another
contact out of contact.
obesity postmenopausal who have the highest prevalence of osteoporosis.
So obesity is common, so is osteoporosis. 3 in 6 women, as you can see, 50% of women have osteoporosis. It's common in men as well. Up to 20% of men have osteoporosis. And when you look at fractures in obesity, obesity is associated with early hip fracture in postmenopausal women. We have data from this 25-year follow-up study. So what actually happens after a hip fracture? Your patient is unable to carry out at least one independent activity of daily living. So after a fracture, quality of life is down. But why does this actually happen? So this is very interesting. If you look at the ancestor of both the bone cell and the fat cell, they share a common ancestor. And the environment and the genes decide which pathway that this mesenchymal stem cells take. So if they go towards adipocytes, your osteoblasts are lesser, and that is how your bones actually suffer. It goes back to their ancestor, which is the mesenchymal stem cell. So if your cells are more into osteoblasts, then there is less adipogenesis. But if they go more into adipogenesis, there are less osteoblasts. So this is a simple pathophysiology which can explain this. But the traditional teaching has been, as the BMI increases, your bone mineral density increases, because we have mechanical loading, right? When we have more mechanical loading because of obesity, that causes the bone mineral density to increase. That has been the traditional teaching. But what happens as BMI increases, it's not just about the bone mineral density, there is increase in falls. As you can see, the many complications of obesity here, fatty liver, OSA, we've spoken all about it, but there's also increased fall risk and immobility, which can lead to fractures. And when we look at bone mineral density alone, when we look at bone mineral density alone, so this you can see across BMI categories. So as BMI increases, you can see the orange graphs there, that BMD is also increasing. But as BMI increases to more than 35, the BMD is actually decreasing. So at the lumbar spine and at the femoral neck as well, the BMD is reducing after a BMI of 35 kg per meter square. So BMD does increase up to a certain BMI, but after that it is actually decreasing, and more so at the femoral neck as compared to the lumbar spine.
Yeah, so that is the thing. With BMI, the BMD is increasing, but at a certain point of time, it does not increase, tend to decrease. So this impact is clear cut that impact of increasing BMI on fracture will also definitely follow some straight line. So this is a bit U-shaped growth, U-shaped graph we are seeing. So after BMD adjustment, after a certain point of time, with rise of BMI, the fracture risk also increases. And another thing we have to mind that the bone mineral density is not all that things that reflects the bone quality or other things. So there is another thing that bone quality is also important, and this is the trabecular bone score, and this is the first Indian study. So this has shown that this morbid obesity may have negative association with bone mass index with bone mineral density. I have already told that. And another thing is that the bone microtexture are found significantly lower in those morbid obesity. So there is a paradoxical value is seen with morbid obesity, as Dr. Rashmi has already told. So this is the trabecular bone score at lumbar spine. This slide has clearly shown that in non-obese, compared to non-obese, obese group has relatively higher TBS, and in the group 3, that is morbidly obese group, has relatively lower, and this value is statistically significant. So trabecular bone score is another thing beyond bone mineral density that helps to understand this progress of BMI, these relationships. This was our meta-analysis authored by me. This has clearly shown that even in diabetes people, especially type 2 diabetes, often accompanied by obesity, these patients also have to have adversely affect type 2 diabetes also adversely affect trabecular bone score, despite having positive effect on bone mineral density. So BMD is not the everything, as I already told that, and there are many effects of obesity on bone, starting from childhood obesity, which causes damage of growth plate, causes early arthritis and risk of fracture and related complications, and also slipped capital femoral epiphysis and also flat feet. impaired mobility. In adult life, this causes osteoarthritis, especially those of knee and hip, and also low back pain that is mechanical. There are also dish that is diffuse with the skeletal hyperostosis and also gait disturbance and even a tendency to fall. So if you tell me something about sarcopenia and sarcopenia.
Yes, so we know that when we speak about obesity, sarcopenic obesity is also another important entity which we commonly see. So sarcopenia is especially relevant in the context of bone health because we know poorer muscle, when we have sarcopenia, we have falls and then that leads to fractures. So this study showed that very interestingly, sarcopenic obesity is more closely associated with knee osteoarthritis than a small sarcopenic obesity. So there's emerging data in this space as well. Sarcopenic obesity may have more complications related to bone compared to non-sarcopenic obesity. And what do the latest guidelines tell us? So this is the Indian Society for Bone and Mineral Research guidelines, which gives us the guidance on osteoporosis management, diagnosis as well. There's nothing on obesity as yet. It was interesting when I went through this guideline for this presentation. It does talk about diabetes, of course, which are complications of obesity that we need to screen them because they are risk factors for fractures, but nothing on obesity as yet, and maybe it's time to add them to the guidelines.
Yeah, then we may reflect. There are now many medicines for obesity and also manage weight in type 2 diabetes also, including GLP-1. So you all know the effect of GLP-1. This is a combination nowadays. There is impact on muscle and also on lean body mass. But there are studies that they negatively affect the muscle mass, and muscle mass is lost in proportionate way with fat mass, and females are more affected in that way. But surprisingly, there are some animal studies that there are differential effects of GLP-1 on this muscle mass with some positive effects. We don't know the explanation, but there may be some positive effects also. So we should take it carefully. So we should consider the proportions of muscle mass loss compared to the fat mass loss, not the absolute muscle mass loss. That is the thing. So we should think beyond BMI. So there is fetal metabolic skeletal phenotype clusters in type 2 diabetes and the GLP-1.
So this is the GLP-1 era, and when we are starting our patients on GLP-1 analogs, we should be thinking about the bone and muscle as well, because we know GLP-1 analogs can cause weight loss, and that in turn can lead to increased risk of fractures. So we did this study in our setup, which looked at clusters in type 2 diabetes. Actually, there was 3 clusters that we found. Cluster 0, which was lean, had the best TBS, the trabecular bone score, and the best microarchitecture. Cluster 1, which had moderate obesity and high fat, had the worst T score compared, when you look at BMD. When cluster 2, which had severe obesity, had the most degraded TBS. So the patients who are eligible, the most eligible for GLP-1 analogs, actually have the worst bone health, and we are going to start them on GLP-1 analogs and put them at further risk of fractures. And when we looked at osteoporosis prevalence by BMD, it was less than group 3, because as we know, obesity can actually have higher BMD but increased risk of fractures. But when we looked at vertebral fracture prevalence, it was highest in the cluster 2, which had the highest BMI and also the most degraded trabecular bone score, which goes to say that your patients who are the most eligible for GLP-1 analogs actually have very poor bone microarchitecture and are at higher risk of fractures. So how do we circumvent this? When we start our patients on GLP-1, it's very important to look at the nutritional aspect, what they're consuming, and also stress on exercise and drugs. For example, vitamin D replacement in patients on obesity, especially candidates who are going to start on GLP-1 analogs, is very important. And when you talk about exercise, resistance training is very, very important for the bone and muscle as well. And of course, like I said, vitamin D, measure it and optimize it before you start your patient on GLP-1 analogs. Again, we have the ISBMR guidance here for general population. 20 nanogram per ml would be enough, but for people with osteoporosis, do target 30. Even for older people who are at risk for osteoporosis, and there's the evidence for levels greater than 40 is unconvincing, and you don't have to target.
Yeah, there may be some drugs also. So we also noted that bimagrumab, that is in big studies, in phase 2 studies, and there is also drug known as apitegromab also. These are big studies. These are under trial and not yet available. So in combination with GLP-1 or something like that, that may preserve the lean mass and prevent sarcopenic obesity also. And we also know this is the focus on. So we should we should focus on the not only the absolute weight loss, we must focus on the patient-centered health outcomes as a whole. Loss of weight, also loss of muscle, also loss of fat, and also the overall quality of life we should also focus. And in a majority of the patients with morbidity, have a poor quality of life. This studies this is an Indian study, and this worsens with increasing severity of obesity. So obesity is not only a pharmacological point of view, so this is also a quality of life point of view that's also very much important. And in physical impact of obesity is the key player that is responsible for both health-related quality of outcomes in patients with morbid obesity. So anything that is not increasing the quality of life, that cannot be adopted by the patient also. And there are some other aspects also. Please,
So of course, mechanical impact of obesity is very, very important. We have Dr. Sambit, Dr. Karda here, who are part of ESI guidelines on management of obesity, and mechanical impact is stressed upon here. Look at osteoarthritis as well as an important complication of bone, like you look for other aspects of obesity. And like I said, medical nutrition therapy is very important in obesity, more so in the GLP-1 era, and adequate replacement of calcium and vitamin D, and ensuring optimal protein intake up to 1 to 1.5 gram per kg is very important, so that your patients get the best benefits of these anti-obesity medications without having sarcopenia or fractures. And we also have bariatric surgery in patients with obesity that again can have a negative impact on bone by virtue of weight loss. And nutrition optimization is again very important in these group of patients as well. And we also have the RSSDI clinical practice recommendations for management of type 2 diabetes, would say that a lower T-score cutoff of -2 should be taken as the threshold for starting anti-osteoporotic medications in people with diabetes, which is often seen with obesity. So again, like I spoke about, we have the ISBMR guidelines as well for screening, and in India, we say that women aged 60 and older and men aged 65 years and older should be screened. And when you look at risk factors, we have diabetes there, but like as I said, we don't have obesity as of now, but maybe it's time for us to look at obesity as a risk factor for screening. Maybe when data accumulates in this space, obesity can even be listed as a risk factor for osteoporosis screening.
So obesity has bone. There are many guidelines that we have also. There is the American Society of Bone and Mineral Research and International Society. So the thing is that I've already told and mentioned with some previous publications that BMD is not everything. So we must look for some other tests, including trabecular bone score, especially patients with diabetes, in type 1 and uncontrolled diabetes mellitus or type 2 diabetes with more than 10 years duration. And there are many nutritional considerations. These are the guideline recommended combinations with nutritional assessment and also monitoring treatment response. Alongside this, there are some recommended intakes like fluid at least 2 to 3 liters per day, protein at 1 to 2.5, increasing dietary fiber, and also energy intake, and also some micronutrients also, including vitamin D and calcium. So this is the expert opinion. I think you can.
Yes, we've spoken about the guidelines for osteoporosis. They're very important to manage sarcopenia as well. And obesity, we know sarcopenic obesity is common, and sarcopenia is a very important risk factor for falls and fractures. So we've spoken about nutritional optimization for people with sarcopenia, but we also have emerging pharmacological therapies for sarcopenia. Anabolic agents such as nandrolone, ticanate for muscle preservation is gaining importance. Especially, I think this is very important in the GLP-1 era, and we should be looking at therapeutic options for sarcopenia as well to optimize bone health and prevent fractures. So in summary, ladies and gentlemen, more weight is not equal to stronger bones. I know that has been the traditional teaching, but we now understand that more weight is not necessarily equal to stronger bones. So do screen for osteoporosis, do screen for sarcopenia, do ask for history of fractures in your patients with obesity, like you would screen for other complications of obesity.
Yeah, that is the thing. So we should look for many things beyond DEXA scan, and we should take other risks for fall and also risk for fractures also. So at conclusion, we said that the patients with obesity has also increased risk of fracture. So sometimes we miss this, and patients sometimes comes with that type of problem. So thank you, panels and also the audience. Thank you.
Thank you.
Thank you, Dr. Lakshmi and Dr. Kannan. That was a great talk. So we'll move to the next topic.
Moving on. Next topic is diet and nutrition, the very basis for weight loss and obesity. So the topic is translating evidence into a clinical practice. I would like to welcome Dr. Sidra Lodi, all the way from Pakistan, up on the stage. Dr. Lodi is an assistant professor of endocrinology. She has FCPS in medicine, FCPS endocrinology, MRCP UK and FRCP in London and Edinburgh, SOF scholarship in endocrinology from UK. She is currently working in King Edward Medical University, Lahore, and her research interests are in obesity, metabolic syndrome, and thyroid. Over to you, Dr. Lodi.
Thank you so much for that kind introduction, and I'm really grateful to all the organizers of this work, especially Dr. Dina, for having us there. And before I go on, let me start by what I felt when I received this, message from Dr. Dina about this. And I thought, there's a whole workshop on nutrition going on. So many people, much more in a better position to talk about this. Should I really be the one to be speaking about diet and nutrition at an obesity conference? And actually, I requested Dr. Dina, but the very next thought was, this is the question that I address several times every day. Because every patient of mine comes and asks me, what should I eat? And with that, I would again take this opportunity to thank you all. Okay, there are no disclosures for this talk. And this is the brief agenda for today. We will be talking very, very briefly. I am sure everybody has had a lot of evidence, had heard a lot of evidence, and is very brief about it. What is the reality, the current landscape, how the evidence is translating into reality, and what are the barriers to it, and are there any solutions? So, the first question, what is the best diet? Can anybody answer that? Somebody who is 50 years, sorry? Exactly, but what if this question was asked 40 years ago? What if this question was asked 30 years ago? And what if this question was asked 20 years ago? The answer keeps on changing. Low fat diet? We started with that. We said fats have the highest caloric burden, so go for a caloric deficit while low fat diet. And then we said, no, it's the insulin carbohydrate leading to the spiking. So we went for a low carb diet. We went for a protein diet, keto diet, heart healthy diet, Mediterranean diet, DASH diet, you name it, and there is a diet with that name. Timing-based diet. Some of them are really going on today. But anybody who wants to know what is the best diet today, you will have all those answers. And today we talk about precision nutrition. We talk about how micronutrients are important, how we should be taking one or other, how should we be adding supplements to our diet. And with that, I would share an anecdote with you. One patient of mine came to me, she was in absolute distress. And the cause of her distress was not her body weight. It was not her medical condition. It was the amount of supplements that she had been prescribed. And she had been prescribed 17 different nutraceutical agents. 17. So that is sometimes a problem with precision nutrition. With that, ladies and gentlemen, I bring you to consider this very, very busy slide. I will take you through this, the South Asian paradox. You have been hearing since morning about how we have a thrifty genotype, how we are programmed for starvation. We have adapted our metabolism over the years, over centuries, over decades, and we have more efficient energy storage. Everything we are eating, it is turning into fat rather than into metabolic products. And the metabolic efficiency is increased. And at the same time, we have this metabolic obesity, visceral obesity, fat storing all in the wrong places. And then, of course, the sarcopenic obesity, which I think needs not to be highlighted. You just heard about it from Dr. Lakshmi and Dr. Asain. Okay, so what is the reality? Where are we at now? This is one reality. What should I eat, doctor? So there are two parts of this question. What should I eat? I already said there's so many diets, everybody is confused. If I try to go on a diet today, I am confused. What is best for me? And doctor. You see, not the nutritionist, not the dietitian, everybody is coming to you with this question. You are not only prescribing medication, you're also prescribing nutrition. Be it a written prescription, be it verbal, be it a handout, but we are all doing it. And then, this. I don't know. But when you explore, what did you actually eat during the day? This is what comes out. One paratha in the morning, just one for lunch. Maybe not paratha, maybe roti. A plate of rice, noodles in the evening, and some things in between. So the answer would be like that for Pakistan, and I am sure it would be same throughout South Asia. But then there's also another part of this. I don't eat anything. So why am I not able to lose weight? Bringing you back to that biological reason that I just highlighted, the thrifty genotype and the visceral obesity, the sarcopenic obesity that we all talk about. How we are differently programmed. So the frustration is genuine. There are two sides of this question as well. And this, very, very important. Have you ever thought what you could not live without? If I told you today, you will never eat X, Y, Z in your life again. For me, that X, Y, Z I cannot live without is roti. But this is the South Asian plate. We cannot live without a staple food in our life. And that is what we are always talking about. Take it out, take it out, take it out. That is why the restrictive diets do not work. So there are three realities that we have talked about. Patients are asking us, they say we do not eat anything, notwithstanding that this all is something, and there are non-negotiable cultural statements. If you take them out of your diet, maybe you can do it at home, but socially you would feel like an outcast. So we have to face these realities as well. Okay. And when we talk about barriers to success, many people would label it as a problem of willpower. But I see it as a multidimensional problem. So these are the 5 pillars, the 5 barriers, the main barriers that I have identified. And I'm sure all of you must be facing them. We talk about the institutional problems, the funding problems. We are isolated, we do not have help. The policies are not there, the infrastructure is not there, frustrations that we face every day. The biology, we said we have a thrifty genotype, we have sarcopenic obesity. Can we really do something about it? Can we change our biology? But then there are things that are related to us. The gaps in the knowledge and confidence. We don't have time. And our roles are undefined. We are having multiple roles, playing multiple roles in the clinic. The psychological problems of the patient, the cognitive load they have, and we are giving them that cognitive load. They get into an all or nothing trap. I ate a piece of cake, my diet is over, my nutritional journey is over. And communication. And then again, for me, the most important, socio-cultural. Meals are a family affair. Just this afternoon, I was talking to a very dear friend of mine, and he said, if I have a separate kitchen from my mother, it will create a danga in the whole village, in the whole family, that we are living in the same city, but we are cooking foods differently, we are eating different foods. Is it tasty? Is the price affordable? Is it convenient to cook? And the cultural anchors, the staples that I talked about. Seeing that the problem is multidimensional, the solutions also have to be varied. One solution would not fit all problems. The first one, the institutional problems, for that, the solution probably lies in what I would suggest would be a multi-level integration. We could integrate into the EMR, the nutritional tracking, one aspect of it. Then we could integrate our health and clinical departments and the policy departments. Obviously, things that we cannot do on our own, but things that we can start talking about, we can start advocating. And then obviously cross-country integration. So multi-level integration. And then the burden on us. How we utilize that little time we have. Can we develop a 2-question screening program, a 3-question, something that identifies, something that builds a foundation of how to go on. So utilizing our time efficiently. And of course, multidisciplinary collaboration. And then our role is to be the beacon of light that brings direction not just in storms, but also in times of peace. Also bringing direction in their lives. Telling them how they can approach. And these are some of the ways that I have thought about and come up from when I reviewed the literature on this. So this is, again, shared to me by a friend. I'm sure you all recognize this. This is a Nepali thali. Something you eat every day, or maybe every other day. You see? Portions. I specifically requested the portions to be what it is usually. And then, these were shared with me by a patient of mine. After I requested her to change the portions. You see? The fiber and the greens in every plate. And this is the breakfast plate. So you can incorporate in every meal. You can make the change. You can, add rice. You can have roti, you could have bread, or you could have anything for that matter. Whatever you like, please don't do away with it. And another thing that we can advise them is 1, 2, 3, 4. The order of food. Water, fiber, protein, and then the starches and foods. These are the references, some of the
कुरा
references
most
to my
important
talk.
हो क्या मैले पनि
And I thank
पेसेन्टलाई
you for your
भन्नु
attention.
इटिङ अर्डर
Because the road to success is always under construction.
Thank you so much, Dr. Lodi, for this enlightening presentation. Also, thank you for finishing on time. So I think this ends the session.
So, thank you so much for having me.
Thank you, Dr. Lakshmi, for the wonderful talk. The paradox of bone health and obesity is often an overlooked concern. Thank you, Dr. Lodi. Your talk reminds us that evidence becomes power.